Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Hey guys, thanks for being listeners of the show. Go to dentalimplantpractices.com and find all of our resources. Also find us on Facebook, Dental Implant Practices page on Facebook, and go to iTunes and leave me a review on iTunes so we can help spread the message. Thanks. Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me today to be introducing Susan Wingrove. Susan, thanks for being on the show.
Thank you. It's great to be here.
Now, Susan, you are a RDH and BS. You've got your Bachelor's in Science and your hygiene degree. You are you're an author. You are a presenter. You're a hygienist, and you have a whole protocol with Wingrove Dynamics. Why don't you tell people a little bit about yourself, some of your past, and kind of bring us up to speed with what you're doing and how you're involved with dental education these days.
Okay. I have been a technical writer since 1978. I have my technical writing degree as well as a hygiene degree, and I've done a lot of research and been experienced with going through FDA trials for regeneration in tissue and bone. I got involved with that with my late husband, who was a periodontist, and developed a product for regeneration. So I've been involved in that research since about 1995, and that in-depth research and working with the anatomy of things led me to designing some dental instruments that I think are used quite internationally now through PDT or Paradise Dental here in Missoula, Montana. And I've also was contacted to write the textbook for Wiley and Blackwell for hygienists on maintenance and disease complications. I do research with Dr. Alfonso Pinheiro. We research cement implantitis in particular, looking at different complications and how to solve them. So that's kind of, and then I do presentations now internationally on protocols. I was a part of the scientific panel for the American College of Prosthodontics when we wrote the ACP Clinical Practice Guidelines as well. So that's kind of my background.
Excellent. Seems like you've spent some good time at a lot of places. Yeah, I actually have a previous interview with Dr. Pinheiro, but we didn't get into as much about the cement issues as we did just, abutment seating and other things. But I know he's got a whole big deal about implant periodontitis, and so we'll cover a lot of that on today's lecture. But I didn't realize you guys had worked together in the past. That's great.
Yeah, he wrote the cement implantitis complications and protocols for my textbook. So one of the chapters is written by Dr. Pinheiro.
Well, you've done a lot in dentistry, and you've been around for quite a while, which is great. And you're doing a lot of things with instrumentation and writing and teaching. What are you doing on a day-to-day, week-to-week, month-to-month basis? I mean, obviously you do some lecturing and some more writing. What fills your day with your time? I know you said you live up in Montana now. Is that right?
That's right. Yeah, I'm in Missoula, Montana. I spend my days writing most of the time. I write on several international journals as well as national journals, and developing some implant maintenance chapters for updates in the doctor manuals and things that they have coming out in the next year, doing the implant maintenance chapters for them. So I spend my time pretty much writing and researching when I'm home or getting ready for another program. So that's kind of how I spend my time.
That's got to be a great place to find inspiration, being up there in Missoula, Montana. I know I've been there, and it's a very peaceful, beautiful part of the country. So I think you chose wisely for a home, and I guess it makes sense if Paradise Dental is up there, since you've got a whole instrument line up there that you've created. So we'll get into that in just a short bit.
Okay.
So I guess we had some topics we wanted to cover. So should we start with the implant maintenance? Is that kind of how we should jump into this?
Sure, that would be fine.
Okay, so let's go into implant maintenance and talk about kind of what the latest research and guidelines are for implant maintenance these days.
Well, probably the latest one that's just come out are the American College of Prosthodontic Guidelines, and they're actually for tooth-borne and implant-borne restorations, but they're not for disease cases. They're for recall and maintenance on anyone that has restorations in their mouth. And they can be downloaded off my Wingrove Dynamics website, but pretty much going through them sets a tone of what kind of is being practiced now as the kind of the standard guidelines that we should go by, with recommending the subgingival air polisher for biofilm removal, for instance. And that's now been available in the U.S. for about 1.5 years now. And the importance of getting rid of the biofilm is kind of the biggest, I think, shift that we have to consider biofilm and calculus removal in any implant maintenance or natural teeth maintenance that we do now. That's a big shift. It had kind of been just calculus type thing, make sure we get it all off. And now we really see how biofilm removal affects the entire body for oral systemic disease reasons. So it's made a kind of a shift, both in home care and maintenance. An example is using the subgingival air polisher at the beginning of the appointment for getting rid of the biofilm. It's not a polisher. It just gets rid of biofilm. So it's kind of misnamed, not a polisher, but it does get rid of the biofilm at the beginning, so you don't take some, bacteria and things from one pocket to the other pocket, for instance. So that's something that's really been a shift, I think, in that. And then for home care, a real shift to what I kind of nicknamed the power tools, with your power toothbrushes and your water picks and things, and now how critical those are now in maintenance. And it's because of the biofilm.
Yeah, so it's more of a shift from kind of the old just scale and tartar removal to the biofilm being the real problem. And so anything we can do at home or in the office to remove that biofilm's probably got to be priority and enemy number one. Is that right?
That's right. I mean, they it's kind of bizarre, but they've done some different mission things where they've left the calculus and just got rid of the biofilm, and things have improved. So it's critical that we kind of shift our thinking to more educating about the whole body, the whole oral systemic inflammation elimination type process, both in our maintenance that we do and in the home care.
What does that look like for a dental office then? If you're saying if someone's got healthy implants or other restorations, you're talking about this subgingival air polisher. What does that look like for an office? I mean, what does that mean for people? Is this different instruments they need to be looking for, or a different approach, or a different mindset altogether?
Yes, it's a different approach altogether, and it's a different protocol, and something that we have to outline for our patients and make sure that we try to get one if we can. It's kind of the I need it now tool for all hygienists to have, but also it's portable. It can be put into the high-speed connection and can be moved around the office, so the doctor can use it too to get rid of biofilm, before he's placing or cementing crowns, or before, during his implant, take it off, clean it, that type of thing. So it's critical to get one. Probably the top one on the market right now is the Action Air and Go Easy, and it's got a tip I feel is the safest around implants and natural teeth. So that would be the one that I would look at. That's from Action. And that should be used at the beginning of the appointment. Really, now they're testing it to use it on even children. Everybody at the beginning of their appointments to be sure that we're professionally getting rid of the biofilm for our patients as one of our protocol steps.
Excellent. Okay. So that's kind of a different mindset. We used to just kind of scale and then get the polishers out and send them home. Now we're really worried about, I guess the bugs are more important. And that, I guess that, I don't know why that comes as a surprise, but I guess it's just coming to the top of the mind for people.
Yeah, I mean it gets pretty particular. I mean, the protocols I've developed, I've put together, what would be the best, mouth rinse you should send your patients home with because of this, or what instrument should you use, and that it's quite different. People need to be aware of this shift and try to work in that direction. And for your dentists that are listening, that one critical step they could make that would be an easy switch over is that when their hygienist, anyone's using any kind of prophy paste in the office, that they switch that to a silica-based polish for all the new dental materials on the market, for instance. No more pumice in our prophy polish. It's damaging all the new dental, materials and things that are out there. And it's safest to use around natural teeth and implants it's something with either diatomaceous earth or silica in it. And there's several on the market. Ivoclar was the first to develop one. Then Directa has the Pro Silica polish, and Preventec has their fine polish. Comes in all the different flavors, but it's diatomaceous earth and there's no pumice involved. So that's an easy shift right off the bat that would at least ensure they're not damaging the new composites and the new restorations and the implants that are in a patient's mouth. Yeah,
making sure that we're not over polishing and over abrading, I guess, to make. Yeah, okay. Does that kind of cover the implant maintenance as far as what's latest and what's going on with the guidelines, you think?
Yeah, we have some. I have that 5-step assessment protocol. It's been out for a few years, but you need to do an assessment on any implant that you have on when you see a patient for the first time or when they're going to have an implant in the mouth. And there's specific guidelines on monitoring them and, when to assess them for this or for that, that kind of thing. So that's something they can look up and read off my website and things. But basically taking X-rays at least once a year now is the recommended for all patients now, especially implant patients, to check the bone level in their mouth around. So that is something critical that sometimes we've kind of slipped on and let people go longer, and now something we really have to pay attention to, especially with implants are involved, that they will check the bone level on them and assess them for those things. And, so working with the correct instruments, the ACP guidelines are very clear. It's no longer acceptable to use plastic or graphite or other debridement tools that are not titanium. And the titanium scalers on the market. Yeah.
So number 2 would be your 5-step assessment will be the X-rays once a year. And then number 2 would be the correct instruments. You're saying no plastic, only titanium instruments, right?
That's right. And that's the ACP guidelines or Academy of Prosthodontic guidelines. But the 5-step protocol really starts with a tissue assessment. And the tissue assessment is to see if it's keratinized, not keratinized, if there's enough attached gingiva around the implant to protect it as well. There, should be 2 millimeters of keratinized tissue is probably the ideal around an implant. You don't often see that, though. It's kind of, been something that we need to look at. An easy assessment for that would be the 3rd step in the assessment, which is to check the implant with a woven or dental tape floss and check to see if there's any fraying or roughing around the implant. Do the circle technique, where you put it on the mesial, distal, crisscross in front, and then you just shimmy it down into the place where the implant meets the crown and take it off. Now there should be no roughing or fraying on it, or there's something down there that shouldn't be down there, it's calculus or residue. And then if there's any bleeding on it, because implants shouldn't bleed. So if they're bleeding, there's kind of a breakdown with the tissue that we should be aware of, and we need to look a little further about that. And in some cases, they will start to lose some bone if the tissue isn't represented there well enough. So it's something they'd have to be referred to a periodontist to have a tissue graft put around that to make sure that it's going to stay healthy for the longest lasting results for an implant. So that's something kind of that new. They talked a lot about it at the Academy of Prosthodontics or the AAP this year when we were at the Perio convention. They talked a lot about the tissue around an implant. So that would be the third one. And the fourth one is checking for mobility and pain. And I don't have occlusion on there because I leave that for the doctor to check. So the doctor should always check with blue indicating paper around an implant, and it should just barely touch it. It's only there as a function to chew, but it shouldn't be catching on it or hitting high on it. It should be something to really monitor. And if it seems to be an issue with that patient, we need to, look at one of the guidelines also are to look at putting them in a night guard or a splint that would protect them for when they're grinding or clenching, because implants don't move. They're just rock solid. Like natural teeth kind of give with those ligaments, but implants don't move. So you have to really check the occlusion. And then the fifth step is, of course, the assessment for bone level, which would be done by radiographs.
Okay, great. So going back to the cleaning, you were talking about the instruments there. No plastic recommendation. That was something that even 5 or 10 years ago was strongly recommended. Now it's just only use of titanium scalers. Is that right?
Yeah. They were concentrating on the fact that the implants before 1993 were machine made and smooth surfaced, and they thought if they scratched them, they would be more apt to have more plaque and things on them. And that's all been, gone. It's since 1993 now. We know the real culprit for Periimplantitis is residue left behind, and that was kind of brought to the forefront with the cement issue. And then we started looking at all these implants under the SIM microscope, and this is where Dr. Pinheiro and I have worked together, and we found instrument residue on the implants. We found cement. We found all kinds of things, and that was really what was causing it. And the only way to avoid leaving something behind, which is critical now, don't leave any residue behind, is to use a like metal. And it's been proven that the best thing is to not change the surface at all. So you're best off to have titanium instruments that fall between Rockwell hardness of 28 to 30. Like the Wingrove set that we designed with PDT is 28 to 30. And there are a couple others that is the critical component that you need to have so that you don't leave any residue behind, and you don't want to be ultrasonicking on an implant surface, mainly because you're going to disrupt the surface and you're going to possibly cause the titanium to be embedded into the tissues, or you're going to affect the oxide layer on the outside of implants. So that's all kind of new information, but just to make it basically simple, you want a set of titanium scalers to debride with that are not going to scratch and not leave residue behind. So there are at least 3 that I know of. There's not, some Rockwell hardnesses are harder on those titanium. It depends whether they're heat treated or not. So you have to be kind of critical about that and look at the recommendations by Gordon Christensen and others that have recommended, like the Wingrove set for that reason. And then the only ultrasonic one that we've found that's safe are the Periimplant Protect tips, which are piezo made by Action. So it's no longer acceptable to put a plastic tip on the end of an ultrasonic and think that you're safe debriding with that we found residue of that also on our testing. So only the piezo implant Protect tips by Action are the only ones that made it through the SIM test that we did.
So it's good that we're being cautious, but sometimes using these softer items, we're actually leaving particles down in there, and we don't want to use anything unsimilar. So having a titanium instrument that is likeness that will get in the areas and clean is the most important part after that biofilm. So it's good that you've got a couple references. I know you've got the scalers that you've designed that we'll point people to, but there's also some ultrasonics through Acteon. So I'm glad that companies are going out and finding a niche market in this, because as the implant field grows and grows, so does the maintenance and the hygiene department of those. And so we need to always be looking at what's the most best for these patients long term, and what is the dentist and hygienist role in order to maintain that investment.
Yeah, it's critical. They need to know what they should recommend for patients to use on home care. They need to know what's safe, but we also need to know what's effective. We can't be like using these soft tips and things thinking, well, we're safer if we're doing that, because we're not safer if we're doing that. That's leaving residue behind. And we need to be effective, and we can't leave residue and debris behind either. So that's kind of a fine line you walk there, but it's been researched out. So that we are getting there on a really good set protocol for people to be, for long term.
Now, kind of in that assess and instrumentation is the whole probing of implants. Where do you feel upon when is best to probe around implants? What are we looking for, and what instruments to use for that?
Yeah, that's been pretty researched out as well. They want you to wait 6 months after the implant's been restored, not placed, but 6 months after it's in function and chewing before you do any probing. And the real ideal time to probe, and it's really going to just show you a baseline for a patient that's going to vary greatly depending on whether it's bone level or tissue level implant placement. It's going to vary by patient. So the ideal time to probe, in my mind, with the research that I've seen, is to do it at 1 year after the implant's been in function, and get a set baseline that you can refer to at every appointment after that. It's the same with films. You get that PA at 1 year, and you refer back to that every year that after it's been in function, and things should not change after that year. If they do, something's going on, that kind of thing. But you can use metal, plastic. There are even some titanium probes now. You can use any of them because you're just using it as a measurement tool. You should never de-plaque with it, run it around or anything, but you should just measure with it. And get a custom reading is what I would recommend on every patient, because a bone level implant on a patient could be right at bone level. And when you probe it, that's 7 millimeters for that person. Then you've got the tissue level one right at bone level that's 0.000 for another patient. So they're very custom, and they're mainly to check to see if there's any changes in those areas. It's kind of difficult to get a bleeding point. They talk a lot about bleeding points, but I travel around and I speak almost every week, and I visit with hygienists that do this on a day-to-day basis, and doing it real light touching like we're supposed to do around implants on the bone to check for bleeding points. They're not seeing them as effectively as they are with the method we've developed for palpating implants. Palpating implants is putting one finger on either side of a single implant or on the ridge, and you're going to push up towards the crown if you're on the lower. If the implant had an apex, you kind of start there and you push, against the tissue on the facial and the lingual, and you're going to see if there's any bleeding coming to the surface or any exudate. And it's almost showing us better if there's any infection going around than even the little bleeding points that we see.
Yeah, what do you call that method?
It's palpating.
Okay, just palpating. It sounds like you're trying to milk it, like you're milking a cow.
Yeah, exactly.
No,
it is. And if you read the research, the facial and the lingual are where a lot of the periimplantitis starts first. And on a 2D film, you are not going to see the bone loss on the facial and the direct lingual like you are in a 3D machine. So you could be losing bone on that facial and lingual, and you can't see it on a 2D film. So if you start to see some bone loss and you get this unexplained bleeding, You do everything you can for that patient, get them back in 6 weeks or 3 months. And if it's still there, they need a 3D image. They need to see if there's something going on in the facial or the lingual they can't see on a 2D film. So that's something a little different than natural teeth we need to be aware of.
Yeah, absolutely. Because it's, I guess I've done that before and not really realized. I was just trying to see, if I could push any exudate out or if there's any issues. And I think that's a beneficial technique because, probing can be very different depending who's doing it. And like you said, what kind of implant you're dealing with. And we're really just looking for signs of infection and disease, instabilities. Yeah, because that bone loss is normally going to happen on that thin facial plate or buccal if it's, or lingual if it's too far that way. And, the gums might hide the bone loss, but they won't hide the infection necessarily. So I think that's a good way to test for it.
Yeah, we've tested it now. We had a group of 25 of us that tested and did protocols and things before I wrote the textbook. And so we've done this since like 2011, 2012. And it's showing us that it's a little bit more effective in showing the signs of infection even.
Yeah, I think you should call it implant milking. And and coin that phrase and write something about it. And I think you'll gain some traction that way. So just get your own little thing going with that because I think that's absolutely accurate in in determining signs of infection or problems with that. So definitely a good adjunct to use. So anything else with the implant maintenance or should we start talking about home care?
We could talk about home care.
Yeah. So, I think that's the other part is, maybe, dentists or hygienists are keeping up to date with what they should do in the office, but they're not really sure, what to recommend to patients to go home. It's, now I know obviously you're talking about more implants. That's very vague. I mean, obviously there's like, single implants or multiple implants and overdentures and complete full arches. So, there's a wide range of, we talk about implant dentistry, but, maybe some of these home care techniques, are transferable. What's the latest and greatest for home care? How should patients be taking care of these, and what do professionals need to be telling these patients or providing for them?
Yeah, it's really based on the biofilm. They need to get their patients knowing they've got to get rid of the biofilm around an implant. Think of it as a circular thing, not a mesial distal thing. It's a different way to floss, for instance, and so forth. And there are 4 basic things they need to do for home care, and that's to brush twice daily with a certain kind of toothpaste. I'll kind of get into that in a minute. Floss, if they use floss, it should be a woven floss or a dental tape type floss, not a real thin floss. It's going to cut that perimucosal seal, so you got to correct kind of floss, or they use a water flosser. And the water flosser has kind of come out on top on that. They, really highly recommend a water flosser, but if the patient doesn't want to purchase one, then you need to go over how to floss an implant. So it has to be either floss or water floss to really get that whole circular area around an implant correctly. So that's kind of a key component. And then the tissue needs to be stimulated around an implant on a daily basis to try to get that keratinized tissue present on the perimucosal seal. And it doesn't happen naturally. It doesn't wash over like with saliva like a natural tooth. So once it's in function, then you're going to want to start using a rubber tip stimulator or a soft pick or easy pick on a daily basis to get that keratinized tissue stimulated around an implant. And then pick a good non-alcohol antimicrobial rinse to rinse with twice daily, or they can put that in the water flosser and use it to combine it. So it's not a tough, long list of what they need to do. They just need to be aware of fluoride issues around implants, and they need to think of it as a round circular thing, not just you can't floss mesial and distal contacts and expect that you've cleaned the implant because you've missed the facial and the lingual then on that, for instance. So the fluoride issue, is coming to the forefront, especially worried about the oxide layer now and corrosion issues. So we really highly recommend that you find a toothpaste that's both kills bacteria and inhibits the bacterial growth. And that's kind of landing on stannous fluoride. And so the new toothpaste that P&G just researched and brought out is excellent. It's the ProHealth Clean Mint, but it's a clean mint version. It's both a neutral pH and it safe fluoride to use around implants. So that's kind of critical to use. And triclosan is in the research also from Colgate that kills bacteria. However, it doesn't inhibit bacterial growth, so it isn't probably as good as stannous, but it's there, and it is proven safe to use on implants. And then there's a formula that I've published several times, but, with sodium fluoride, anytime you're using sodium fluoride above 3.0, it has to be a neutral pH product that, is used. So anything like in your 5,000 parts per million fluoride that you use, if there's sodium, you're going to need to make sure that that's a neutral pH product before you use it, or it might not be safe around implants. It can remove that oxide layer and make the titanium possibly, a corrosion issue for the implant. So it is critical to look at our mouth rinses and look at our toothpaste and make sure we're recommending something safe to use around implants. And mouth rinses are huge right now. That there's a couple that have come to the forefront with mouth rinses too, and that's chlorine dioxide has come to the head of the heap because it kills all the bugs in both periodontal and peri-implant disease. And we're no longer doing any alcohol mouth rinses. You notice everybody's gone to zero. So the one that I highly recommend is Closis or OralCare. Those are two chlorine dioxide products that are safe to use long term. They can use twice a day for sure around their implants every day. They don't have to restrict it. And really refrain from recommending any chlorhexidine around implants is also a critical thing to know, is to switch from that to chlorine dioxide is important. So that's kind of a little quick synopsis of that.
Sure. Now, for the mouth rinses, you said OralCare and what?
Closis.
Okay. And you said no chlorhexidine around implants?
Right. Well, they're still researching that out. I usually do everything based on evidence-based research, and they're highly recommending we take a second look at that. And for any pre and post rinse around even natural tooth or implants, especially if we're using growth factors and we want to encourage regeneration. Remember, I'm a regeneration researcher, and we found that it's best not to use chlorhexidine around that. So for pre and post rinses now, it's more highly recommended to use chlorine dioxide as your pre and post rinse for healing reasons, for no interference with growth factors and regeneration. So need to take a second look at that as a pre and post rinse if you're not already doing that.
Okay, so for brushing, obviously you want an electric toothbrush of some sort, right?
Right. That's what's recommended, just because the biofilm might be more sticky and so forth. And probably the only electric toothbrush that's come out with specific tips for implants is P&G OralB. Dr. Masad done some research and came out with a couple of tips that will work around the full fixed cases and so forth. And it's kind of nice because the tips will fit on any OralB toothbrush, even an old one or a new one. And the Interdental brush that they've developed, interproximal looking, it's real small, will go underneath those, all in 4 cases and so forth, and inside of the overdenture. And so I like that for that reason. They have the tips that are specific for implants. You can't just use a regular tip on a battery toothbrush and expect it to be the same, around implants. We're trying to look at where the implant meets the crown. So we need to have something specific. It's just like instruments. You need a specific instrument that isn't necessarily a tooth design. It's an implant design. So that's also, we're trying to develop some new instruments that will be more implant designed, not just a tooth design used on an implant, for instance. You need to look at that and recommend the right thing for your patient.
So you're talking more about like the OralB, is that right?
Yeah, the OralB is the one that's got the tips that are specific for implants.
So OralB with the tips for implants, you're looking at the Crest Pro Health Mint Clean or Clean Mint version of toothpaste, flossing with a thick or woven, using an air or water flosser. Sorry, what type of water flosser do you like? What is out there that you're seeing for that?
Well, the only one that, I remember I tell you, I only put it in my program or my papers if it's evidence-based. And the only one with good, solid research is Waterpik. Waterpik has their research done, and they also have a plaque-seeking tip, which I'd highly recommend. That plaque-seeking tip is amazing. It actually has little bristles on the end of it, too. So if you haven't looked into Waterpiks lately, they've really changed with the number of tips that they have, and they have tips that are specific for implants as well. So it's nice that these companies are really looking at that, because they predict really 2019, 2020 here in the U.S., we'll probably see a patient with one implant in their mouth in almost every patient we see. So we're going to need to know what to do with these implants and what home care products are the right ones to recommend.
Yeah, no, I mean, I completely agree. I mean, their implants are on the rise. They're becoming the most popular choice of tooth replacement, way to fix teeth. And, it's not just one thing to get them in. We need to take care of them appropriately.
Well, that's it. They'll last till 5 years, pretty much in most of the research type things. But we want them to last our patients, as long as possible, maybe their lifetime if we can, So we want to offer them what's going to make their implant last the longest. And in my mind, it's home care. I mean, it's what you do at home on a daily basis. And it's researched out now. They need to see a dental professional at least every 6 months for a professional in-office implant maintenance visit, which means specific things like the biofilm remover with the subgingival air polisher and so forth. At least every 6 months, probably cuts it in half of them developing implantitis. So it's pretty critical. Our role and the home care role makes a huge difference. Absolutely.
Any other home care tips that we missed?
I think the interdental brushes are, I teach in Europe, and interdental brushes are highly used. They're scrubbing the biofilm off, disrupting the biofilm. We always want to kind of think of it that way, scrub or disrupt. And so interdental brushes, look at Tepi and Sunstar for some real good examples of multiple sizes in those things. But that's something to also kind of go along with this, get rid of the biofilm kind of thing. If you haven't looked at them lately, to look at those as well.
Yeah, absolutely. Anything we can do just to get up there and break that up, I think is a great thing. So whether, depending what your circumstance is, might mean certain aids for you that are different for the person, but it's good to have maybe an understanding of what they all are, so that as you see them, you can relate them, patient to patient. Well, I guess let's talk about, to follow up here at the end, let's talk about Periimplantitis, involving, maybe a lot of that is from cement, and then what some protocols can be to help try to treat or manage that, and where to go with that, because obviously that's a huge issue that everyone's aware of nowadays, but then it's kind of like, okay, we're aware of it now, what do we do about it? And so maybe you can aid in the discussion with that for us.
Yeah, there's some good assessment guidelines out now. once if the patient has perimucositis, we want to obviously try to catch it there where there's no bone loss and it's just inflammation around the implant. And we want to use the number one tool for that is the subgingival air polisher around there and the correct instruments to debride with. So you do that for perimucositis. Now, periimplantitis, we want to look at, and I liked the Fromm and Rosen classification that talks about bone loss in comparison to the length of the implant, because I think it's something that people can identify with. They can measure on the film on the computer screen how long is that implant, and if it's over 25% bone loss in comparison to the length of the implant, it needs to be looked at as something that might need to be taken care of on a more, either by a specialist or to be regenerated in some way with bone if necessary. So anything over 25% of the implant length for bone loss. So we can figure that out, and it gives us a good concrete thing to look at. Again, you're monitoring that once a year, that 1 year film if you have it. If you don't have it, you take it when the new patient came in, and that would be your baseline, and then that should not change. If it does, or if it's over 25% the length of the implant, then you need to look at something possibly going on with that implant, get a 3D film, and then do a proper periimplantitis treatment for that, which is basically a guided bone regenerative procedure for, you have to get the bone back. You can't just flap open an implant and clean it and flap it back again and expect it's going to regenerate. You have to treat the implant surface, and that's where they've done some research on what do you treat the implant surface with and so forth. But then it basically needs to have bone and be a guided bone regenerative treatment. But for cements, we do have some good guidelines for cements now, and there's a technique that Dr. Pinheiro and Wadhwani put together. They call the blue moose technique, which it's basically blue moose, which is indicating impression material, but they squeeze that into the implant crown when it comes back from the lab, and they make a dye, and the dye then is a little bit more sterile than the one that came back from the lab. And when you're cementing an implant, you put very small amount of cement. It needs very, very, very little cement. I think you have to be really cautious with that, and it needs minimal cement. Just rim the top inside of the crown, put it on the die, and squish it all off onto the die. So all the excess cement goes onto the die, and then the assistant would hand it to the doctor, and they put it in the mouth and cement the crown so that the excess is all left on the die and not in the mouth. So that's a really good technique. And now they're coming out with some good cements. Ivoclar Vivident's kind of leading the way on that. They have Telio CS cement that is really good for cementing temporarily crowns on the abutment for while the implant is osseointegrating. And the nice thing about that is that it doesn't pull on the implant. It's easy removability when you go to put the permanent one on. And then they have a good self-adhesive resin called SpeedSim Plus, and that's also made by Ivoclar Vivident, so you could get a hold of a rep and kind of go over it with a rep sometime. But that SpeedSim Plus is really interesting because it can show up in an X-ray if there's any excessive cement very clearly. It glows on the X-ray if there's any cement left behind. And we've been having trouble seeing cement on 2D films. It's just not showing up, even if it's there. So this is a good way for you to use a product that you could know will glow on any kind of film if there's any leftover excess cement you need to take care of. So that's a nice thing, but it has to be done correctly using like the blue mousse technique, so you don't leave any excess if possible around the implant.
Yeah, I think that technique's great. I'm always surprised how much cement I really extrude out and how little you really need to put your crowns on. I'm always worried the crown's going to come off, and yet they never do. But I think, cement amount is a huge deal, and cement type, like you said, you need to find one that if you actually have it in there, you can see it on the x-ray, because I'm here to tell you, just other cements, you won't see them on the x-ray. So you think that Speed Sim Plus is the best one to get?
Yes, it's by far got the most research, and there's a lot of good points on it that you can use it on, most of the implant crowns now. So if they look into it with an Ivoclar, even at rep, they could tell them more of the specifics with that. But we like it because we can definitely see it. And the problem is that once it sets up like that, you want something like a Speed Sim Plus, where they have a technique that you can softly take it off right away and that kind of thing, because you want to make sure it's not going to seep down into the threads. And if you leave it just set, like on any kind of cement, it can seep down into those threads and below the bone line, and you can't take it off even if you wanted to, So it's not like cleaning cement off a natural tooth. It is different. So you just need to be aware of that. It can seep down into the threads. I have a lot of pictures of lost implants with cement all down the thread. So it seeped down there, and there was no way that even if you wanted to at the time of cementation, it was below where you could go with an instrument to clean it off. So you just have to put the right amount on to begin with. And I like that blue mousse technique, or they've got techniques now where they can cement them outside of the mouth, and then they put in the button and screw it into the implant, and they just have to fill the access hole. So there's a couple of different ways to just make it safer to use. And there's some good points of cementing. The screws become loose on screw retain too. So there's their ins and outs of both techniques, so.
Yeah, I think it's okay to use both if you know how to use them properly. But if you're not cementing properly, you're going to do more damage than you will good long term. So it's nice that a company finally took the initiative and made something halfway decent that actually shows up on the x-rays and is easy to use. I feel like that's been a long time coming, but I'm glad Ivoclar is really leading the charge with that. So, yeah, definitely.
So, they can find most of these resources on my website, wingrovedynamics.com, and information on the Wingrove Titanium Implant Scalers and things all on that. I developed those actually with my late husband, who was a periodontist and an implant specialist, mostly specialized in saving failing implants. And so in the early 90s, we realized we were having issues with things other than cement. There was something else on those implants. So it's something that we've known for quite a while. And he helped me design those 3 instruments that could use on anything, any type of implants, but specifically for wide-based, narrow-based, and specialty areas, not just you figure it out yourself with a regular dental scaler, which doesn't work. You have to be specific for implants.
Yeah, so your website, Wingrove Dynamics, that's WINGROVE Dynamics.com. You said people are going to find stuff there. What should they look for about that? Obviously, you've got a textbook to buy, which I'm sure is fantastic for any dentist or hygienist. You've got the ability for people to kind of see some presentations and articles that you've written. What else is on there?
There's videos on there, using like a new scaler that I worked with Linda Miller on for PDT that's called the Queen of Hearts, which they can look and watch a video on, and different videos are on there and articles, and I hope, resources for people. For Straumann, I wrote a ProArch guideline sheet, white paper for doctors, and it goes over maintenance and home care for full fixed patients that they can download as well and look at. it's pretty applicable to any full fixed arch case. So that's something they can look for on the website as well.
Yeah, those are all fascinating things. I mean, I think people just need to know who's got the right information, having the right tools, and knowing where to go for the understanding of the science and the data. Like you said, I like the fact that everything you do say, well, here's what the research shows, and I love that about you is you're not just kind of buying the next product. You're saying, okay, well, let's look at what the science says, and then let's figure out a way to adapt what we're doing based upon the science. And I think that's really important, so that we're knowing and making recommendations that are going to work for people.
Yeah, at the end of the day, I hope that from my almost 40 years of working in the dental field now, and I did work until a few years ago, actually, in offices and things. And I think that we realize what you really need to do, and you need concrete things that you can recommend and do safely and effectively for your patients. And it's difficult to find the time to do all that research yourself. That you've got to do your second job, take everybody to hockey practice or something after work. So, people need to have this kind of looked at and get some good protocols. I did that in the textbook. It's more of a research guide than even a textbook. And it goes over these in checklist type formulas so that people can use them and just go back in their off and do it, that kind of thing. So, and feel comfortable about that. That was what I was hoping would be possible for both dentists and hygienists. There's a chapter in there by Dr. Pinheiro on cement implantitis, for instance, and Dr. Robert Horowitz is also in the book for talking about different guided bone regeneration and things like what are all these different things that we need to look at for regeneration nowadays. So hope that they'll enjoy that and they can get that on Amazon or Wiley as well.
Yeah, absolutely. I mean, I think, it's great that you've got all these resources for people. What's the next part of this year look like for you? I know you still go out and do some teaching. I mean, what's your involvement with travel and other commitments and things you're doing?
Well, I travel almost every week and go speak for different specialty practices and study clubs. And I do a program for Liz Graham Presents where we do 6 weekends together where we do hands-on and go through both natural teeth and implants to really give an overview of what's the latest and what you need to look at for hygienists. So we do that across the U.S. about 6 weekends a year. And then I am a professor in Italy. So I have grad students that I work with over there, mostly internet-wise, and then I'll go there next May to teach again and that kind of thing. So we have a lot of international connections that I do as well. So it's nice because I learn from them too, what's the latest over there and bring it back here. And, you get more information when you go out. I go twice a year overseas and most of the time I'm speaking though here in the U.S. or Canada.
Excellent. So it sounds like you're busy, and I know what you mean. If you're out teaching and lecturing, you're learning as much as you are as presenting. So it's good that you're stays active in as many venues as you do, and I know it keeps your mind sharp on the topics and keeps you up to date with what's going on in the world, which is always changing and improving as science evolves.
Exactly.
So if people wanted to check you out, the Wingrove Dynamics is the best place to do it. The textbook and the articles are probably the best place. And then to get a hold of some of your instruments, it looks like there's a link on there too. You can scroll down on the main page to PDT Dental for Paradise Dental Technologies. Anything else that people should know about you, or anything else that you've got to share with the Implant Practices podcast listeners?
Oh, I don't know. I guess I just hope that they can gain from this and be able to use it, effectively and safely. And then that gives them time for normal life balance where they go out and enjoy. And I know I go out and I hike these mountains and things. It kind of gives me an overall sense of peace. So I hope they just go out and live each moment. So I hope that for them, that they don't have to do so much. Maybe they can follow these and gain from them as I learn too.
Yeah, it's definitely important. That's the thing I love about dentistry is it is hard work, but a lot of people within the field understand, the importance of that balance and relationships and things. And I'm glad you're out there in the good country. And, I know, hopefully people have some take home, valuable lessons from this conversation. I really appreciate your time with me today. It's been a pleasure talking with you. Look forward to getting your book and some of your instruments and hope that others do as well. So really appreciate you being on the show today and look forward to maybe catching me again sometime, okay?
That sounds good. Thank you.
Thank you for your time.